Video I am discussing about recall history, that is about short stature and tall stature. Normally short stature come on exam. So the exam task are there are three tasks come on short stature. First of all, short stature in known asthmatic twin, 11-year-old, nothing in history apart from just being short. His discussions got good comments. Then I covered everything and came to diagnosis that it was a constitutional short stature, but gave pass. Then 3 year pass as examiner thought, just thought I didn't involve the patient much but involved only mom. I had thought I had initially asked few questions to mom, then started asking him later everything, and they were having joint communications. So constitutional short stature, we know that nothing will find, everything is positive here, and he will be catch his height later. That is one common exam. Another short stature history come, that a teenager with Turner syndrome with concern about her short stature, already on hormone injections. So teenager, that is a girl, we know the Turner syndrome girl, they have delayed puberty and some unusual features. These are that is Turner syndrome, short stature, already on hormone injections. So when we drug history take, that is hormone injections. And another is also come short stature, that is 7-year-old boy with Digeorge syndrome, mom concerned with short stature, full PMH and BH, previous cardiac procedure, now repair, no significant immunodeficiency, no other factors that would affect the growth, short stature associated with syndrome. So Digeorge syndrome, another cause of short stature, it come on exam. But we know that Digeorge syndrome feature, they have unusual features, facial, that is cleft lip, cleft palate, we know that. And also they're telling there is a cardiac procedure on past. If we take the history, they have a cardiac procedure or surgery or any cardiac disease involved. We know that Digeorge syndrome associated with some cardiac disease. And then significant immunodeficiency, how can we know that? Repeated maybe any infections like that. So these three history common exam. Now I am telling how can we take the short stature. Only the structure I will tell, management another video I will tell. So short stature, first like a chief complaints, a boy or girl come with short stature. Present history will ask when first you notice that. How did you know that? Do you have or his growth chart with you? What about his weight and head circumference? His measure, sitting height, standing height, arm span. So we ask about what about his weight and head circumference. So one of the short stature we know that hypothyroidism, short and the high head circumference is also needed, and he's measuring anyone measuring about the sitting height and standing height. Then is he started to be like a man or woman? Size of the private area in boys and breast part in girls. So puberty started or not, we'll ask. Then what about the parents' height, age of the puberty of the parents in tall stature? So these are we ask about parent height. We will ask because a familiar short stature can be present, a familiar tall stature, and age of puberty of the parents because of the constitutional delay of short stature. Now, did you notice any unusual features? Unusual features, we know some disease condition, especially Digeorge syndrome, come on exams. Unusual features. What about his mentality and intellectual functions? Very important. Any other concern? Any chronic conditions he's suffering or not? Because some chronic conditions causes short statures. Then fever, weight, activity, sleep. These are we will ask general conditions. So I'm again repeating the present history. We are asking the onset when you first know that. Do you have his growth chart or growth velocity? What about his anyone measure his standing height, sitting height? What about his weight, his head circumference, parent height? Then when he does he start look adult like puberty started in boys? Private part is in large, and girl this is breast part. We ask. Then when the parents have started their puberty, what about his behavior and intellectual functions? Then any unusual features present or not? Any other concerning chronic condition he's suffering not? Then fever, weight, activity state. Okay. Then we go the systemic review one by one from CNS. Sign of increased intracranial temperature signs, ICT signs, abnormal any movement, abnormal gait, fits, numbness, previous back, vision concern, yellow eye, hearing concern, behavioral changes, irritability. Normal questions. Then GIT, tummy size, tummy pain, throwing up, yellowish discoloration of eye, oral thrush, oral anal soreness, anal itching. In chest, we'll ask that any recurrent barks, cough, snoring sound, and severe heart racing, exercise intolerance, chest pain, fainting attack, urinary precaution, blood pressures. Then MSK, skin spots, fingers, oral, anal flexures. Any skin spots, okay, acne, abnormal hair distribution, hirsutism. Any abnormal hair distribution, lump, swelling anywhere, neck swelling, hair and nail, bone or joint pain, carving of the back, any asymmetry in the body, like back with Weidman syndrome, small hands and feet, Prader-Willi syndrome. and stria. So any asymmetry in the body, we can ask small hands and feet, Prader-Willi syndrome. Any unusual features, we can ask like that. Endocrine, hot or cold intolerance for thyroid, very important. Hot or cold intolerance. Then hematology, pallor, bruise, recurrent bugs, and history of blood transfusions. So systemic review as usual, we ask everything. Then past history, we know 5T IOA. It is very important. What is 5T? Any treatment he is taking? Any previous any admissions? If admitted, then is there any ICU needed or not? Then also any surgery, previous any operation occur or not? So Dijon syndrome, we find that cardiac involvement. The child may be taking cardiac treatment. Then previous admissions, lots of time for immunodeficiency. Then any blood transfusion, team involved, trauma, previous any trauma present or not. These are 5T. Very important. The drug if on steroid. If we find steroid, any side effects of steroid, especially methylphenidate, if short, sex hormones, these are. Parental history is very important. Like pregnancy, maternal disease, drugs, illicit drugs. So mother will ask that. That's just a routine questions. I ask you, ma'am, do you take any illegal medicine during your pregnancy? Delivery time, type, first cry, postnatal birth weight, NICU admissions, meconium passage, yellowish discoloration, feeding problems after birth, belly button loss, heel prick test, hearing test. This is also needed. Puberty, if in that is time, then Hertz history, fully Hertz history. How can you take puberty? Hertz history will take how does this affect him? Does he start his menstruations? He's now adult. In this age, child are taking lots of experience in their life, drugs, alcohol. Does he taken that? Does he ever depressed? He does not want to live in this life. Anyone special in his life, sexually active or not? Taking contraception or not? Educations, is that education is affected or not? That is Hertz history. Everything about home, what is his relation with home people. Okay, the nutrition very important. If there is over or underweight, any feeding problem, type of food, number of the meals who prepare food for him, content in each meals. So very important. Development in details we'll ask, like is that he's growing like pears, he's sitting, standing, everything, walking. Vaccination up to date, any extra shot, normal allergy, foods or drugs, family history of similar condition, consanguinity. It is very important, history of similar conditions. Social, is the child aware of his condition or not? Psychological impact, how does his condition affect the family? School, is he going to school? Is it mainstream or special school? If not, ask anyone talk to you regarding appropriate education plan for him. So there are lots of questions. Short stature, normally short stature, I told you, Dijon syndrome come, Turner syndrome come, and constant delay of short stature come. So short stature, some DD I am telling, normal and abnormal. Normal variants are familiar short stature and constant delay of growth. Mm. So familiar short stature, constant delay is normal. Abnormal is pathological short stature. That is, some are non-dysphormic, like small for gestational age, like preterm baby, and some are due to nutritional cause, malnutrition, malabsorption, chronic illness, psychosocial dwarfism. And now proportionate short stature occur in Down syndrome, Turner syndrome, Prader-Willi syndrome, Russell-Silver syndrome, Noonan syndrome, Beckwith-Whiteman syndrome. And disproportionate short stature we find achondroplasia, skeletal dysplasia, rickets, osteogenesis imperfecta. And short trunk we find mucopolysaccharidosis, scoliosis, post-radiations. Failure to grow. Height is more than the weight. That is growth hormone deficiency, hypothyroidism, Cushing syndrome, Albright hereditary osteodystrophy. These are loss of course with such hypothyroidism, hot and cold intolerance, weight we can, and school performance we can identify. Then Cushing syndrome, any drug side effects about weight, any abnormal hair distributions we are asking, any unusual feature we are excluding all the these morphic features. And familiar short stature we are asking, is there family member, constitutional delay about his start his puberty or not, and about his parents puberty. So this is all about short stature history. Thank you very much.